Hello, everybody. My name is Andrew, and today I will be presenting on coronary artery disease in adult males, examining social determinants of health through the socio-ecological model. I hope you find it both informative and enjoyable. Coronary artery disease is a condition resulting from the buildup of plaque in the walls of arteries that ultimately leads to the restriction of blood flow to the heart. Also referred to as coronary heart disease, ischemic heart disease, or atherosclerosis, CAD can develop in anybody, but it most commonly affects and kills adult males both in the United States and around the world. CAD can result from a combination of several medically related causes, including stress, physical inactivity, and poor nutrition. Additionally, non-medical factors have also been shown to affect the likelihood of CAD, factors that influence health on a smaller individual level and broader external conditions that play an underlying role in various health outcomes. These broader conditions are often associated with or directly relate to social determinants of health, such as socioeconomic status, health literacy, and the environment in which people live, and provide another angle of understanding and addressing CAD as a health concern. Coronary artery disease falls under the broader blanket of cardiovascular disease, but is the most common subcategory of heart disease. It was responsible for 382,820 deaths in the United States in the year 2020. Adult males tend to develop the associated risk factors for CAD earlier in life and therefore are more likely to die sooner from its onset. Several well-established social determinants can potentially accelerate the likelihood of CAD in adult males, each of which can become more prevalent on an individual, communal, and societal level. For purposes of this presentation, socioeconomic status is a determinant that is weaved into each of these different elements and should therefore be considered the most closely. For a better representation of these influences on CAD, the socio-ecological model can be used to both create and promote the most accurate and effective prevention methods. So why the socio-ecological model? This framework is often used by the Centers for Disease Control and Prevention to examine the factors that may perpetuate violence in individuals, but it can also outline other potential health threats. The SEM is useful for illustrating the multitude of interworking factors that influence health conditions on an individual level, a relationship level, a community level, and a societal level. In visualizing the risk factors at each level, it makes it easier to continue to work towards the most effective prevention methods to minimize incidence. This model aids in a more comprehensive scope of health issues such as coronary artery disease. This overlapping representation of different layers allows for a clearer understanding of the small-scale, more personal aspects and the broader elements that tend to pave the way for greater consideration of the social determinants of health. Still, certain social determinants are relevant even at lower levels of this framework and will be discussed further. Beginning at the individual level, this ring of the socio-ecological model deals with an individual's personal history and any biological factors that may influence their risk of coronary artery disease. Health behaviors or comorbidities play a substantial role in the development of CAD, with physical and mental stressors typically at the forefront of the list. Stress tends to manifest itself in the form of high blood pressure, which, if left to become a chronic problem, can very quickly contribute to CAD. Along with this, smoking, physical inactivity, and poor dietary intake are factors that increase the risk for CAD. Individuals who have diabetes or are genetically predisposed to heart disease are also at risk for developing CAD. Middle-aged individuals are at greater risk of developing CAD over time, with adult males being more affected than adult females. At this level, lower socioeconomic status has been shown to contribute to stress levels in males that struggle to have enough financial freedom to provide for their families, let alone provide for themselves. This in turn can pave the way for smoking or poorer eating habits to set in as a means of stress management, thus further increasing their risk of developing CAD. Similarly, an individual of lower socioeconomic status may also have lower health literacy and may not necessarily have the resources or information to make the most informed health decisions to minimize their chances of developing CAD. The next ring in the socio-ecological model is the relationship level, which examines an individual's closer, more immediate relationships that may influence the risk of coronary artery disease. Maintaining the individual factors from the previous slide, especially when considering stress, family structure and the dynamic of familial relationships come into play here. Relationships between friends, colleagues, and coworkers also have a hand in affecting the chances of CAD. Support in the workplace, such as the ease of requesting personal time off and being able to offload overwhelming work demands, makes a huge difference in performance and stress management. Regular social interactions are critical for maintaining and improving mental health. This, along with any recreational activities that can strengthen these relationships and encourage potential physical activity, are a means of minimizing the possibility of developing CAD. Again, the effects of socioeconomic status can be seen here. As the traditional family provider, males tend to bear this burden at an exceptionally high level, which could in turn contribute to the likelihood of developing CAD from a financial standpoint. With this in mind, the conditions of someone's neighborhood, such as those living in impoverished communities, would only add to this burden for a male to be this figure in an artificially more challenging environment to become financially stable. The community level of the socio-ecological model explores the settings in which individuals interact and function. It is where their previously mentioned relationships take place, and it looks at the influences on coronary artery disease that may exist there. The availability, affordability, and objective quality of homes in a given community are related to the health of individuals and the relationships they hope to create and preserve here. The environmental conditions, such as air and water pollution and public safety, feed into the ability to maintain optimal health that may otherwise contribute to CAD precursors. Access to food options that are more nutritious is critical in ensuring better eating habits to minimize the effects of artificial or fatty foods that increase the risk of CAD. The availability of quality healthcare in a community is essential for routine medical visits to keep a watchful eye on any early signs of CAD. Socioeconomic status acts as a determinant that would allow adult males to afford a house and raise and provide for a family, ideally in a safe and healthy environment. It is also a make or break to acquire healthier food options for themselves and their families. The availability of healthcare within a community, let alone its quality, can be of potential concern for adult males to receive the care they need to avoid the chances of CAD. The most external shell of the socio-ecological model is the societal level, the area that deals with the broader established social norms and public policies that may be influencing an individual's risk for coronary artery disease. Existing policies that make health insurance and healthcare as a whole near impossible to afford make it difficult for just about anybody to stay on top of their health to avoid developing CAD. Additionally, any public policy that continues to campaign for tobacco products and smoking in general inadvertently continue to promote its usage. Educational institutions that do not prioritize optimal health education in the form of proper diet and exercise are connected to perpetuating the living factors that may increase the risk for CAD. Discrimination, unfortunately, remains ingrained within certain communities and can also be found in healthcare settings, which allow for marginalization of certain patient demographics that are seeking treatment. Lack of any concern for public safety in areas with notoriously high crime make it difficult for individuals to thrive and grow within their own communities. They are also less likely to participate in any recreational physical activities should they be available, due to concern of any adverse events taking place. Each of the previously mentioned social determinants, along with others that are not discussed here, exist at this level with socioeconomic status taking the forefront. Financial security would ameliorate many of the concerns that would otherwise influence risk factors of CAD, which in turn would increase the likelihood of being in a better living environment and being relatively health conscientious. Those that find themselves challenged with any of these elements would be at an inherent disadvantage and therefore at a greater risk of developing CAD and being subject to its consequences. After exploring different social determinants of health using the socio-ecological model, it is apparent that non-medical and medical interventions are required to mitigate the effects of coronary artery disease. Although males are statistically more at risk than females, these interventions can theoretically be applied to anybody that may be at risk for CAD. From a non medical standpoint, addressing the social determinants in this context would likely be the most effective. Improving food security to promote better dietary habits and increasing the availability of recreational areas to promote physical activity can aid in minimizing direct health risks to CAD. Making positive health behaviors a priority in education systems, as well as within working environments, can work to make people more aware of their choices and actions that may put them at risk of CAD. Working to improve affordability of healthcare and health insurance, as well as working to abolish preferential treatment based on culture, race, or any other demographic, are critical in decreasing the gap and delays in receiving treatment. From the medical side, increasing pharmaceutical research and development to introduce potential preventative regimens, as well as manage the symptoms of those who may be experiencing CAD, is a necessity. Continued genetic research to explore the safety and efficacy of gene editing that may help those that are genetically predisposed to CAD can also become a potential therapeutic. Lastly, the long-term impacts of e-cigarette smoking and vaping on CAD and cardiovascular disease as a whole, and how they may differ from traditional tobacco smoking, is a venture that will likely need to be explored. To conclude this presentation, it is clear that coronary artery disease remains a critical and growing public health concern as the leading cause of death in adult males globally. In considering its multifaceted list of risk factors, a more holistic understanding of the medical and non-medical elements is vital for a joint approach in working to mitigate its effects. The socio-ecological model acts as a bridge between these two entities, examining both the physical medical concerns along with the underlying social determinants of health that drive these risks a step further. Ultimately, further collaboration between organizations and professionals in various fields is needed to provide the resources to continue work to minimize the incidence of CAD in not only adult males, but for all. Thank you for taking the time to tune into my presentation. I hope it was clear and concise, and I look forward to any discussions to follow. Have a good evening.